Hi, y'all, and welcome back to Professor Truelove's Concepts for Nurses series. And I am Professor Terry Truelove. In this episode, part of the continuing concepts with cardiologic nursing, we're going to look at heart failures, the causes of heart failures, and how heart failure is categorized. Sources for this episode include Iggy's Medical Surgical Nursing and Soul's Introduction to Critical Care Nursing. Heart failure can be a result of any structural or functional cardiac disorder which impairs the ability of the ventricles to fill up or to eject blood. It affects approximately 5 million people in the United States, and there are 500,000 new cases that are diagnosed in a typical year. These cost up to $50 billion in healthcare costs annually, and 300,000 people die from this disease. Heart failure is defined as the inability of the pumping action of the heart to meet metabolic requirements of the tissue for oxygen and nutrition. It occurs because the heart is too weak to pump blood out of the ventricles. And we can talk about systolic failure, which is from decreased contractility, or there is not enough blood that will be able to get to the tissues, or diastolic failure, which is decreased filling. The blood can become congested before getting to the ventricles. Heart failure affects cardiac output, so it's important to remember HR times SV equals CO, where HR is heart rate, or the amount of times the ventricles contract in 1 minute. SV is stroke volume, or the amount of blood pumped out of the ventricle in one contraction, and that is measured in milliliters. This is determined by preload, afterload, and myocardial contractility. CO is cardiac output, or the amount of blood pumped out of the ventricle over 1 minute, measured in liters per minute. In heart failure, the cardiac output is not sufficient enough to meet the metabolic needs of the tissues. Stroke volume is determined by preload, afterload, and myocardial contractility. Preload is the amount of blood that has entered the ventricles at end diastole. It stretches the ventricles, increasing recoil, and therefore increasing stroke volume. Afterload is the amount of resistance the left ventricle must overcome in order to circulate blood. Increased resistance equals increased myocardial workload. EF is ejection fraction. This is the percentage of blood ejected from the ventricle in one contraction. Remember that some blood will always remain in the ventricle, hence it is a fraction and not a complete emptying. The normal EF is between 55 and 75%, or this means that 55 to 75% of the blood in the left ventricles is ejected with each contraction. An EF of less than 55% may indicate heart failure. The loads themselves are affected by outside sources. Preload is affected by both venous return and the compliance of the circulatory system, that is, how elastic the overall circulatory system is, while afterload is affected by arterial blood pressures and pulmonary artery pressures, as well as by the effects of vascular disease. Heart failure at its essence means that you have a poor pump. When the heart is not pumping enough blood, there are manifestations of the different systems. If we're talking about the brain, this means changes in LOC, dizziness, confusion, and agitation. With the kidneys, this means decreased urine output and water retention. With the skeletal muscles, increased fatigue, especially during work. With the lungs, decreased gas exchange. And with the liver, decreased metabolic and digestive actions. If, however, the ventricles are prevented from properly filling up, this also affects the entire system because all organs return blood to the heart. If the heart begins to fail or become weaker, it is unable to pump the blood forward and the fluid backs up. This causes increased pressure to all of the organs, blood congests in those organs, and the organs begin to fail because this congestion prevents proper circulation. The systems will react individually to heart failure. In the lungs, the congestion increases the effort of breathing. Fluid escapes into the alveoli. This is known as pulmonary edema. The fluid interferes with oxygen exchange, This causes hypoxia, and it exacerbates difficulty breathing. This can lead to dyspnea on exertion, which may be an early symptom. As the condition progresses, the dyspnea may become worse, leading to a condition called orthopnea, in which the patient needs to sleep sitting up in order to breathe easier. They may use pillows to sit themselves up, and eventually leading to paroxysmal nocturnal dyspnea, or PND, which may be a late symptom. With PND, the patient suffers shortness of breath while they are sleeping. Since the kidneys receive such a large portion of the cardiac output, they are also heavily impacted. Decreased cardiac output results in decreased blood flow to the kidneys. This decreased blood flow to the renal arteries decreases renal function, including urine output. The decreased urine output results in the retention of sodium and water, and this retention of sodium and water is a compensatory mechanism to decrease renal blood flow. However, the long-term effects can be devastating. The liver also tries to adapt to the changes brought about by heart failure. This is because blood becomes congested entering the chest. This fluid backs up into the liver and extremities because the heart is unable to move the blood out as quickly as it is received. The liver attempts to store excess venous volume. This backup of fluid is known as edema, and it is dependent on positioning. So the feet and legs are usually the first place that edema is noticed. This, combined with the decreased urine output, leads to an increase in body weight. Systolic heart failure is the most common type of heart failure. The ejection fraction is less than 40%, and it is frequently caused by impaired contractility because of such conditions or problems such as myocardial infarction or cardiogenic shock. It can be caused by increased afterload, such as brought about by hypertension, or it can be caused by cardiomyopathy or valvular disease. On the other hand, diastolic failure is the inability of the ventricles to fully relax and fill up with blood. This results in decreased stroke volume and cardiac output. The nurse should note the presence of pulmonary congestion, pulmonary hypertension, ventricular hypertrophy. However, since it's not a problem with blood getting out, the ejection fraction is probably going to be normal. Other types of heart failure include a mix of both systolic and diastolic failure, in which the ejection fraction is less than 35% and pulmonary hypertension exists. And note this is noted most in a condition called dilated cardiomyopathy. Also, another type of failure is called biventricular failure. This is when both the left and right ventricles are dilated, weak, and have poor filling and emptying capacities. The body can compensate for heart failure for a certain amount of time, but eventually it will become exhausted. Some of those early responses include tachycardia. Eventually, ventricular dilation will take place. We have to think about Frank-Starling's law, which states that the stroke volume of the heart increases in response to an increase in the volume of blood in the ventricles. Before contraction, that is, the end of diastolic volume, when all other factors are remaining constant. Another compensatory response is brought about by myocardial hypertrophy. That is, the muscles of the heart become thicker. The intention of these compensatory responses is to increase cardiac output, either by increasing the heart rate, increasing contractility, or increasing the size of the muscle that's pushing on the ventricles. However, the overall idea is to maintain homeostasis. One of the first things that's going to happen, therefore, is a sympathetic nervous system response. This increases cardiac output by increasing stroke volume and heart rate. It increases afterload, which preserves perfusion. The renal response occurs because of decreased renal perfusion. This leads to activation of the renin-angiotensin system. In addition, aldosterone is released, and this leads to the retention of sodium and water. Both of these lead to a release of antidiuretic hormone, as well as atrial and B-type natriuretic peptides. All of these slow the decompensation that is taking place because of the heart failure. Because of the atrial natriuretic peptides and B-type natriuretic peptides, or ANP and BNP, are released in response to increased atrial volume and to increased ventricular pressures. They both promote venous and arterial dilation, which reduces preload and afterload. However, prolonged heart failure does lead to the depletion of these factors. In addition, other regulatory responses include pro-inflammatory cytokines. These are released in response to cardiac injury and go to depress cardiac function, which has a negative effect on cardiac output, but which is helpful because it reduces myocardial oxygen demand. These compensatory responses are indeed two-sided. Initially, increased heart rate does increase cardiac output, so it is initially an effective adaptive response. However, over time, this leads to increased cardiac workload, leading to increased oxygen consumption. At that point, the mechanism becomes inadequate, leading to decreased cardiac output. The same problems can be found with the adaptation of ventricular dilation. Remember, originally it is an enlargement of the heart chambers. This causes increased left ventricular pressures and is initially an effective adaptive response. However, over time, this mechanism becomes inadequate as the ventricles become weaker and weaker. This leads to decreased cardiac output. As a reminder, Frank-Starling's law says that the more I stretch the ventricle, the faster and harder their recoil will be. That increases cardiac output. However, while it is true that this is initially an effective adaptive response, that is, increasing venous return results in increased force of contraction, over time, the myocardial stretch decreases as these ventricular filling times increase. This causes ineffective ventricular contraction, which leads to decreased cardiac output. Like any muscle that has increased work, the muscles of the heart will become thicker too. This is ventricular hypertrophy. This increase in muscle mass and cardiac wall thickness will increase the stroke volume, and it is initially an effective adaptive response. However, over time, the muscles continue to weaken. They increase in size and thickness. This wall thickness and muscle mass begins to decrease the size of the ventricle. This means there is less volume in the ventricles, leading to poor contractility and decreased cardiac output. So in summary, all the adaptive responses that the body has will initially compensate for your decreased cardiac output. However, these very same adaptations eventually will cause the decrease in cardiac output that is the hallmark of heart failure. We have reached the end of this episode, but hang in there. There are more episodes coming. As always, I hope you learned a little bit. I hope you'll come back to hear some more. And if you do, I'll see you then. Take care.